Welcome to Deep Dive Ortho, the show dedicated to unpacking complex medical topics, providing you with those essential insights and perhaps a few surprising facts to sharpen your clinical edge. Today, we're taking a deep dive into an absolutely critical, yet often subtly challenging aspect of human anatomy: the intricate vascular supply of the hand and the clinical methods we lean on to assess it. The hand, as we all know, is a biological marvel, a masterpiece of design, vital for nearly every human interaction, from the most delicate surgical stitch to a powerful grip. But what truly underpins its incredible function and resilience? It's a rich, often redundant network of blood vessels, absolutely essential for its very survival. Understanding this network isn't just academic, it's paramount for anyone in clinical practice, dictating everything from safe cannulation to complex reconstructive procedures.
Indeed. The hand's vascular anatomy provides a fascinating case study in collateral circulation, a testament to the body's inherent intelligent redundancy for critical functions. Our mission today is to thoroughly explore the radial and ulnar arterial systems, the vital palmar arches, those common yet often clinically significant anatomical variations, and crucial clinical assessments like the Allen test. We'll be looking through a focused lens, highlighting their direct relevance to patient safety, surgical decision-making, and frankly, avoiding those dreaded complications. We'll explore why a seemingly simple bedside test can carry such profound implications for patient outcomes, and how a truly deep understanding of these pathways informs everyday practice.
All right, let's unpack this by starting at the very foundation of the hand's blood supply. For those of us living and breathing upper limb anatomy, we know the brachial artery is key. But what's often overlooked about its critical bifurcation at the antecubital fossa, beyond its basic anatomical position, that makes it so clinically relevant for us?
It's a great question because while the brachial artery's division into radial and ulnar branches at the antecubital fossa is textbook, what's easily overlooked is the variability in its exact point of division. Sometimes it's higher, sometimes lower, and that can catch you off guard, particularly when attempting access or planning dissection. The subclavian to axillary to brachial artery pathway is the standard, of course, originating from the aortic arch on the left or the brachiocephalic on the right, but it's this final bifurcation into the radial and ulnar that truly defines the starting point of the hand's primary arterial supply. This point sets the stage for the hand's complex vascular network, which, despite its apparent simplicity in diagrams, is full of anatomical surprises.
You mentioned variability, which is something we constantly grapple with in orthopedics. But beyond just being tubes that carry blood, what defines the actual structure of these arteries, and how does that contribute to their dynamic function? It's not just a static plumbing system, is it?
Precisely. No, not at all. Arterial walls are a sophisticated dynamic structure comprised of three distinct layers, each critical to their function. The innermost is the tunica intima, lined by endothelial cells. This layer is paramount for maintaining smooth blood flow, preventing platelet aggregation and subsequent clotting. Now, for the experienced clinician, the subtle but critical implication here lies in its vulnerability. Even minor endothelial dysfunction, often seen in conditions like diabetes or atherosclerosis, can initiate a cascade leading to thrombosis.
Right.
This is why a seemingly healthy-looking vessel can suddenly occlude, potentially jeopardizing a flap or a digit. Next, we have the tunica media, the middle layer, predominantly composed of smooth muscle and elastic tissue. This layer is the artery's engine that's responsible for the pulsatile motion, propelling blood distally. And its elasticity allows the artery to accommodate the systolic surge and recoil to maintain diastolic pressure.
So the recoil is key.
Absolutely. If this layer stiffens, say, with age or hypertension, you lose that critical elastic recoil, impacting overall perfusion pressure. Finally, the outermost layer is the tunica adventitia, or tunica externa, which provides structural support and anchors the artery to surrounding tissues. It's often thought of as just a protective sheath, but it contains its own vasa vasorum, tiny vessels supplying the arterial wall itself. The integrity and healthy interaction of all three layers are absolutely fundamental to effective, resilient circulation throughout the limb.
So that dynamic interaction of the layers is truly the secret sauce. Does that mean then that chronic conditions that stiffen or damage, say, the tunica media, could manifest in subtle ways a busy clinician might miss if they're not looking beyond basic pulse assessment?
Absolutely. The interplay is profound. A stiffened tunica media, for example, might still give you a palpable pulse, but the compliance, the ability to distend and recoil, is compromised. This can reduce overall flow, especially in microcirculation, which might only become evident in subtle signs like delayed capillary refill, unexplained pallor, or even a reduced ability to recover from a minor ischemic insult.
Oh, I see.
This highlights why a holistic assessment, not just a single pulse check, is vital.
Excellent point. Now let's get into the individual arteries themselves, starting with the radial artery. For mid-senior professionals, we know its general course. But what are the specific anatomical landmarks or relationships that make it clinically unique and often a first choice for arterial access?
Well, the radial artery, often referred to as the lateral lifeline, courses along the lateral or radial side of the forearm. Its clinical uniqueness comes from its accessibility. It's nestled quite distinctly between the flexor carpi radialis and brachyradialis muscles, making it remarkably superficial and palpable, which is why it's so commonly used for arterial line insertion or radial pulse assessment.
Makes sense.
Distally, it takes a fascinating detour.
Yeah.
It passes through the first extensor compartment of the wrist, a key anatomical point where it runs between the abductor pollicis longus and extensor pollicis brevis tendons. This anatomical relationship is critical, as conditions like the Quervain's tenosynovitis in this compartment can sometimes mimic vascular issues due to swelling.
Right. That's a good differential to keep in mind.
From there, it angles dorsally, entering the dorsal carpus, embarking on its journey to supply the intricate structures of the hand.
And once it reaches the hand, what are its primary contributions? Beyond just giving off branches, what territories does it truly own in terms of blood supply?
Once in the hand, the radial artery makes several vital contributions, and it has a significant ownership of the thumb and radial aspect of the index finger. It gives off a superficial palmar branch, which, while smaller, contributes to the superficial palmar arch. More significantly for the deep structures, its deep palmar branch becomes the primary source of the deep palmar arch, a crucial anastomotic connection we'll discuss shortly. But perhaps its most direct and critical supply is to the thumb itself, via the princeps pollicis artery, which typically divides into two, providing the main blood supply to the thumb.
The prince of the thumb.
Exactly. It also gives off the radialis indetus artery, supplying the radial side of the index finger. The clinical takeaway here is clear. Compromise to the radial artery, particularly proximally, puts the thumb and radial index finger at highest risk of ischemia, as they are often directly dependent on it despite the collateral network. And of course, its superficial location and consistent course in the anatomical snuff box make it a readily palpable pulse point. Frequently used not just for heart rate, but also for detecting subtle differences in blood flow, which could indicate more proximal conditions like coarctation of the aorta or Berger disease.
So the radial artery plays a significant direct role in digital supply, particularly for the thumb, and a foundational role in forming those crucial palmar arches. Now, what about its counterpart, the ulnar artery? What's its medial journey like, and what are its unique clinical considerations?
Conversely, the ulnar artery, which we consider the medial mainstay, runs along the medial or ulnar side of the forearm. It has a slightly deeper and more protected course, largely positioned beneath the flexor carpi ulnaris muscle, which makes it less accessible for routine palpation compared to the radial artery.
Right.
At the wrist, it takes a specific and clinically important path. It travels lateral to the ulnar nerve and enters a well-defined anatomical tunnel known as Guillaume's canal.
Ah, Guillaume's canal. That's a crucial choke point, isn't it? We often associate it with nerve compression. What's the specific clinical relevance of the ulnar artery's passage through there?
You're absolutely spot on. Guillaume's canal is a fibrous tunnel bounded by the pisiform medially and the hook of the hamate laterally, with the punsohamate ligament forming its roof. It's where both the ulnar artery and nerve pass through. The clinical relevance is profound. Any impact trauma, like a fall directly onto the palm, can cause swelling within this confined space, leading not just to classic ulnar nerve compression symptoms, but also, crucially, to a potential compression or injury of the ulnar artery itself.
The hypothenar hammer syndrome connection.
Precisely. This can manifest as vasospasm, thrombosis, or even a true aneurysm, as seen in hypothenar hammer syndrome. So when a patient presents with ulnar-sided hand pain, numbness, or even unexplained coldness and pallor post-injury, always think Guillaume's canal and assess both the nerves and the artery.
Fascinating how a seemingly bony canal can have such dual neurovascular implications. Once it's through Guillaume's canal, what is the ulnar artery's main contribution to the hand circulation?
Within Guillaume's canal, the ulnar artery divides into its superficial and deep branches. The superficial branch is the primary, indeed the dominant, contributor to the superficial palmar arch, forming the majority of this critical network. The deep branch of the ulnar artery, while smaller, provides a minor but important contribution to the deep palmar arch. Together, the branches of both the radial and ulnar arteries extensively form these superficial and deep palmar arches, creating a robust, interconnected anastomotic network. This redundancy is the hand's primary defense against ischemic injury. ensuring that if one main arterial pathway is compromised, the collateral circulation can often maintain adequate perfusion. It's a truly remarkable testament to the body's self-preservation mechanisms, built right into the hand's core. So these arches are clearly central to the hand's blood supply and its remarkable resilience. Let's really delve into their distinct characteristics. What are the key differences between the superficial and deep palmar arches, and why is understanding those differences so indispensable? Absolutely. The hand's very survival, especially its ability to withstand injury or surgical intervention, often hinges on the completeness and patency of these arches. They are truly the critical collateral network. First, the superficial palmar arch. This arch is positioned more distally than the deep arch, lying directly beneath the palmar fascia. Clinically, you can approximate its surface marking at the level of a line drawn across the palm, parallel to the distal edge of the fully abducted thumb.
Okay.
It's predominantly supplied by the ulnar artery, which is typically the larger contributor, with only a smaller input, often quite variable, from the superficial branch of the radial artery. It typically gives rise to 6 principal branches, including a deep communicating branch that connects to the deep arch, the digital artery for the little finger, and 4 common digital arteries that then further divide into proper digital arteries to supply the fingers. Crucially, the superficial arch is complete, meaning it forms a continuous loop supplying all digits for approximately 80% of patients. This 80% completeness is a significant factor in surgical planning.
Right, 1 in 5 might not have it complete.
Exactly. It means 1 in 5 patients might not have this primary redundancy. Then we have the deep palmar arch. This arch lies more proximally than its superficial counterpart, positioned deep beneath the flexor tendons and near the base of the metacarpals. Its surface marking is roughly 1 finger breadth proximal to the superficial arch. Its primary supply comes from the deep branch of the radial artery, which is essentially a direct continuation of the radial artery as it crosses the hand. It receives a minor contribution from the deep branch of the ulnar artery, completing the loop. The deep palmar arch's branches include the princeps pollicis and radialis indicis arteries, which often arise directly from it, and common digital arteries for the 2nd to 4th web spaces. What's truly remarkable about the deep palmar arch is its consistency. It's reported to be complete at a very high percentage of patients, as high as 97% in some older studies. However, some more recent detailed cadaveric studies have reported completeness around 76.9%.
That significant range in reported completeness highlights a crucial clinical challenge, doesn't it? We can't always assume full redundancy. What does this variability mean for our preoperative planning, especially when we're relying on that collateral flow for high-stakes procedures?
It's a critical point you raise. This variability means we must never assume. If we're planning a procedure that might compromise one of the main arteries, particularly the radial for harvesting, that 76.9% figure for deep arch completeness, while still high, introduces a definite element of risk that requires meticulous preoperative assessment. This high rate of anastomotic redundancy is generally a key protective mechanism against ischemia, making it a reliable backup system when complete. The deep palmar arch also gives off palmar metacarpal arteries that course distally to anastomose with the common digital branches from the superficial arch, creating further interconnections.
More backup systems.
Indeed. It also has recurrent branches that supply the carpal bones and radiocarpal joint. By supplying the adductor pollicis, dorsal interossei, palmar interossei, and lumbrical muscles, it plays a vital role in powering the deep intrinsic muscles of the hand. So its integrity is crucial not just for perfusion, but for hand function itself.
It's clear that these arches are the primary players, ensuring robust blood flow throughout the hand. But are there other, perhaps less prominent vessels that still contribute significantly to the hand's vascularity, particularly on the dorsal side where we don't often think of the major players?
Absolutely. Beyond the primary radial and ulnar arteries and their direct contributions to the palmar arches, other vessels contribute significantly, especially to the dorsal hand. The anterior and posterior interosseous arteries, which branch off the common interosseous artery itself, typically a branch of the ulnar artery, play an important role. These supply blood to the dorsal hand, and their perforating branches are vital connections between the dorsal carpal network and the deep arteries of the hand. The dorsal carpal arch, formed by branches of both the radial and ulnar arteries, further gives rise to the dorsal metacarpal arteries, which then provide dorsal digital arteries. While perhaps not as extensively discussed as the palmar arches in terms of overall hand viability, these dorsal contributions are crucial for the overall perfusion and viability of the hand, particularly in dorsal trauma, complex fractures, or when planning dorsal flaps where these vessels become the primary conduits for tissue transfer.
Like the first dorsal metacarpal artery flap.
Precisely. The first dorsal metacarpal artery is a common donor vessel for thumb reconstruction.
We've covered the intricate arterial inflow, bringing oxygenated blood to the hand. But the return journey, venous drainage, is equally vital for preventing congestion, waste product accumulation, and maintaining tissue health. How does the hand manage its venous return, and are there any specific clinical implications of its dual system?
You're spot on. Efficient venous drainage is indeed equally vital. In the hand, venous drainage occurs through two main systems, deep and superficial. The deep veins typically follow the deep arterial system, often running as vena comitantes, literally accompanying veins.
Yes, the paired veins.
Exactly. This is critical in surgery because it means you're almost never dissecting a single vessel in isolation. You'll typically encounter the paired veins alongside the artery. This profoundly impacts how we approach arterial repair or harvest, requiring meticulous dissection to avoid damaging the vena comitantes, which could compromise venous return. It also highlights the countercurrent heat exchange, where heat from the artery transfers to the cooler venous blood, vital for maintaining hand temperature, especially in cold environments.
Clever design.
The superficial venous system, on the other hand, is predominantly found on the dorsum of the hand. This network of superficial veins is highly visible and readily accessible, which is why it's so commonly used for intravenous access.
Our go-to for cannulas.
Precisely. This dorsal network drains into the larger cephalic and basilic vein systems in the forearm. The cephalic vein drains the lateral aspect, while the basilic vein drains the medial aspect. Both deep and superficial systems are crucial. Deep veins handle the bulk of muscle and bone drainage, while superficial veins are vital for skin and subcutaneous tissue. Compromise to either system, whether from trauma, compression, or iatrogenic injury, can lead to significant edema, impaired tissue viability, and prolonged recovery. So understanding both is paramount.
Given this intricate and often variable vascular network, how do we clinically assess its integrity, especially before procedures that might compromise it? This brings us to the widely known yet sometimes debated Allen test. What's its core purpose and historical significance?
Precisely. The Allen test is a fundamental screening technique, first described by Dr. Edgar Van Noys Allen, a Mayo Clinic professor specializing in peripheral vascular disease, back in 1929. Its primary aim is to evaluate collateral blood flow to the hand, specifically assessing the patency of the ulnar and radial arteries, and, by extension, the presence of a complete palmar arch. The crucial point here is its simplicity and bedside applicability. A revised version, the Modified Allen Test, or MAT, was subsequently developed by Dr. Irving Wright in 1952. Unlike the original, the MAT assesses each hand individually and can evaluate either radial or ulnar arterial flow in isolation, thereby making it the generally preferred method due to its more focused evaluation of each primary artery's contribution.
So when exactly is it absolutely crucial to perform this test? Are there particular clinical scenarios where skipping it could lead to significant patient risk?
This test is absolutely necessary whenever considering procedures that may potentially compromise the arterial patency of the hand. The risks of not performing it or misinterpreting it can be catastrophic. Key indications include radial artery cannulation or catheterization, commonly performed for arterial line placement in critical care or for blood gas analysis.
Standard ICU procedure.
Indeed. It's vital before cardiac catheterization, where the radial artery is increasingly chosen as the access site. And critically, prior to artery harvesting for forearm flaps or bypass grafting, especially for coronary artery bypass surgery, where the radial artery is often a preferred conduit due to its diameter, length, and ease of harvest. A positive test indicates adequate dual blood supply to the hand, suggesting that the hand can maintain perfusion even if one artery is temporarily or permanently occluded. Conversely, a negative test points to insufficient dual supply and may contraindicate the planned procedure due to a significantly increased risk of hand ischemia and arterial thrombosis.
So it guides critical decisions.
Absolutely. This diagnostic insight is paramount for patient safety, allowing us to pivot to alternative access sites or graft choices, thereby mitigating severe complications like tissue necrosis or even limb loss.
So we're talking about avoiding potentially life-altering complications, and there are no absolute contraindications for performing the Allen test itself, correct? It's a safe assessment to undertake.
That's entirely correct. The test itself is non-invasive, quick, and generally considered very safe, with no absolute contraindications to its performance. The real danger lies in the absence of its performance when clinically indicated, or a misinterpretation of its results. The test's utility is in identifying risk, not creating it.
Right. For our listeners, especially those who might be newer to certain clinical settings or need a precise refresher, could you walk us through the detailed step-by-step technique of performing the modified Allen test? Precision in technique is everything here.
Of course. Precision is paramount. To perform the modified Allen test, you begin by having the patient sit comfortably, flex their arm at the elbow, and clench their fist tightly. This maneuver is crucial as it helps to exsanguinate the hand, meaning it pushes venous and arterial blood out of the superficial and deep vessels.
Squeezing the blood out.
Exactly. Next, the examiner simultaneously compresses both the ulnar and radial arteries at the wrist, effectively occluding blood flow from both major vessels into the hand. While maintaining this compression, the patient then extends their elbow to approximately 180 degrees. It's important to take care to avoid overextension here,
Why is that?
as this could potentially lead to a false negative result by inadvertently compromising collateral flow from the brachial artery further proximally, giving you a misleadingly poor return.
Okay. Makes sense.
With the arteries still compressed, the patient then unclenches their fist, and at this point, the palm should appear distinctly white or pallid, confirming successful exsanguination and arterial occlusion. Then, while still maintaining pressure on the radial artery, the compression on the ulnar artery is released. In a normothermic patient with adequate circulation, the color should return to the entire palm within 5 to 15 seconds.
That 5 to 15-second window is key.
Yes, this rapid return of rubor, indicating a pink flush, signifies a positive test, suggesting that the ulnar artery, along with its collateral connections via the palmar arches, can adequately perfuse the hand if the radial artery is compromised. If the rubor of the hand does not return within 15 seconds, it is considered a negative test, indicating inadequate circulation via the ulnar artery pathway. To fully assess collateral blood flow, this process can then be repeated on the same hand, but this time you would release the radial artery first, while continuing to compress the ulnar artery.
Testing the radial supply now.
Exactly. This allows for the evaluation of the radial artery's collateral contribution. The principle remains the same. A swift return of color indicates adequate flow from the released artery, supported by the palmar arches. This systematic approach ensures a comprehensive, albeit clinical, assessment of the hand's vascular resilience, which is essential for identifying those at higher risk.
While the manual technique is fundamental, you mentioned that supplemental instrumentation can really enhance accuracy and provide objective data. How do these tools aid in performing the Allen test, especially in those challenging cases where a manual assessment might be ambiguous?
Indeed, while hands alone suffice for a basic assessment, additional tools can significantly improve accuracy and provide objective, quantifiable data, particularly in situations where a patient's baseline condition might confound the manual test. For instance, if a patient presents with conditions like Raynaud phenomenon, which can cause persistently cool or pale hands.
Yes, that could be tricky.
Exactly. A manual assessment can be ambiguous, potentially leading to a false negative. In such cases, a Doppler probe placed on the thenar eminence, the fleshy part at the base of the thumb, can be very beneficial. It allows direct auscultation of arterial flow, giving you an audible confirmation of patency and return of flow. Another widely used and simpler method is incorporating a pulse oximeter on the thumb or index finger.
The SATS probe.
Exactly. With this technique, you first obtain a baseline oxygen saturation and waveform reading for the digit. Then you proceed with the Allen test steps. Compress both radial and ulnar arteries until the pulse oximeter waveform disappears and saturation drops to 0, confirming complete occlusion. When you release the ulnar artery, you objectively record the waveform and saturation return. If these values align with the baseline, it provides clear, objective evidence of adequate collateral flow.
Much more objective.
Considerably. Furthermore, more advanced methods like digital plethysmography, which measures changes in volume in a digit to assess pulsatile flow, and duplex ultrasonography with dynamic testing, which provides real-time imaging of blood flow and allows for compression to visualize changes, can also be utilized for even more precise assessments, especially in complex vascular cases. Intraoperatively, an Acklin microvascular clamp can temporarily occlude a vessel, and a Doppler probe can then confirm preoperative findings or assess the patency of vessels after a repair or anastomosis. These objective methods provide a much clearer picture of the collateral circulation and are especially valuable when a high-stakes procedure, like a free tissue transfer, is planned.
That's a powerful argument for leveraging technology. And who is qualified to perform this vital assessment? Is it limited to specific specialties or levels of training, or is it a broader skill set?
Not at all. The Allen test is a foundational skill in patient assessment, reflecting a basic understanding of vascular principles. Any trained healthcare professional, including physicians, physician assistants, nurse practitioners, nurses, and respiratory therapists, can and indeed should perform the Allen test whenever indicated. It's part of the essential toolkit for ensuring patient safety in procedures affecting hand circulation. It's a team effort in preventing complications.
The test sounds straightforward, but there seems to be some ongoing dialogue and even debate around its predictive power and reliability, especially with that inter-observer variability you mentioned. What's the latest consensus on the clinical significance of this test, and what does the evidence truly suggest about its utility in our daily practice?
That's an absolutely crucial point, and it's a conversation that continues to evolve in the medical community. The most significant risk mitigated by performing the Allen test is preventing catastrophic hand ischemia and subsequent tissue loss if circulation is severely compromised. Imagine a scenario where a radial artery is harvested for a bypass graft and the ulnar collateral circulation is insufficient. The consequences could be dire, leading to significant tissue damage or even necessitating amputation.
A devastating outcome.
Absolutely. If the radial artery is compromised, tissue loss is most likely to occur in the thumb and the nares eminence, as these regions are anatomically furthest from the remaining ulnar blood supply and most directly dependent on the radial artery. This is why understanding the specific areas of perfusion is so critical. While the radial artery is often chosen for vascular access due to its superficial location and palpability, ischemia distal to the puncture site, though rare, is a severe complication. Regarding its accuracy, the evidence has been somewhat varied, leading to the ongoing discussion. For instance, a study did find that the modified Allen test demonstrated a sensitivity of 73.2% and a specificity of 97.1% for identifying circulatory deficits before radial artery harvest for coronary artery bypass grafting.
So good specificity, less sensitivity.
Generally, yes. This suggests it's quite good at ruling out patients who don't have an issue, but less sensitive in catching all who do. However, a meta-analysis published in 2017 reported a lower specificity of 93% and, perhaps more concerningly, an inter-observer agreement rate of only 71.5%.
Ouch, that's quite low agreement.
It is. This latter point raises significant concerns about its overall utility when performed manually, as it indicates a notable degree of variability between different examiners. Despite these concerns, a more recent study demonstrated that the modified Allen test has a high negative predictive value. Meaning, if it's negative, it likely is negative. Precisely. It means that if the test is negative, indicating inadequate collateral flow, it is highly likely that there truly is an issue. Consequently, the authors of that study still recommend follow-up diagnostic testing with objective methods, such as pulse oximetry or Doppler ultrasound, if the manual Allen test result is negative. The consensus appears to be that while the manual Allen test is a valuable initial screen, especially due to its simplicity and non-invasiveness, objective confirmation is advisable when there's any doubt or negative finding, given the critical implications of hand ischemia.
Rely on objective data when in doubt.
It's a classic example of when clinical judgment must be reinforced by objective data.
This highlights the critical importance of not relying on a single data point and, where possible, leveraging objective technology. Beyond the individual clinician, how does the effective use of the Allen test and the subsequent management of its findings enhance overall healthcare team outcomes? It sounds like a true interprofessional effort.
It absolutely is an interprofessional effort. Because the Allen test can be performed by various trained professionals, physicians, physician assistants, nurse practitioners, nurses, and respiratory therapists, it allows for a coordinated and consistent approach to patient assessment right from the physician. When all team members understand the importance of this test and are proficient in its performance, it creates a robust safety net. Consistent pre-procedural use of the Allen test, along with coordinated efforts by all team members to monitor for post-procedural complications, such as changes in hand color, temperature, sensation, or capillary refill time, is paramount.
Constant vigilance post-procedure.
It's exactly. Prompt notification of team leaders, if any signs of compromised circulation appear, can facilitate swift intervention. This proactive and collaborative approach significantly enhances patient safety and can dramatically improve overall outcomes by minimizing ischemic effects and allowing for timely reconstruction, such as primary anastomosis or vein grafting, if radial arterial blood flow is unfortunately disrupted. It's a testament to how teamwork in medicine can prevent serious harm and ensure the best possible functional recovery.
That makes perfect sense. Now, we've discussed the typical arterial patterns that provide the hand's lifelines, but anatomical variations are the bane and beauty of clinical practice. How common are they in the hand's arterial supply, and what forms do they take that might genuinely surprise us, even as mid-senior professionals?
Hand artery variations are, in fact, not uncommon and are a crucial consideration in clinical practice. They are more the rule than the exception, which makes our preoperative assessment so vital. These variations can arise from various points, not just the typical bifurcation of the ulnar and radial arteries from the brachial artery. For instance, while the ulnar artery is usually the larger of the two main arteries supplying the hand, it can be the same size or even significantly smaller than the radial artery in some individuals.
Which would impact dominance.
Profoundly. This size difference can profoundly affect the dominance of blood supply and the reliability of one artery to compensate for the other. Furthermore, the completeness of palmar anastomosis, which we just discussed, can vary significantly among individuals. Some may even have duplicate palmar arches, providing an extra layer of invaluable redundancy.
Nature hedging its bets.
Indeed. Conversely, and critically, in a small percentage of cases, the deep palmar arch may not have any connections to the ulnar artery, meaning its supply is almost entirely reliant on the radial artery, a real clinical trap if unrecognized. A large three-dimensional analysis of 220 cadaveric hands revealed some interesting prevalence rates. The superficial palmar arch was complete in 96.4% of cases and incomplete in 3.6%. However, for the deep palmar arch, completeness was observed in 76.9% of the hands studied, which is a notably lower rate than some older reports that cite up to 97%.
That 76.9% is quite a bit lower than the classic teaching.
It is. This particular study also interestingly found that about half of all cases exhibited collateral pathways for the palmar side originating from the dorsum, sometimes even serving as the main arterial source of the deep palmar arch, a truly surprising nugget.
Wow, supply coming from the back door, essentially.
Exactly. This highlights the incredible, almost improvisational adaptability of the vascular network. The blood supply to the thumb, for example, can also vary considerably, coming from the princeps pollicis artery, the first dorsal metacarpal artery, or various combinations of these vessels. In some cases, the princeps pollicis artery itself was found to be absent in 2.4% of cases.
So thumb supply isn't guaranteed from one source.
Not at all. These numerous, often subtle variations underscore the absolute importance of thorough preoperative assessment, as relying solely on textbook normal anatomy can lead to critical misjudgments and compromise patient outcomes. Always expect the unexpected.
Always expect the unexpected is a great mantra for anatomy. Given that, are there any particularly significant or rare variations that warrant extra attention due to their truly profound clinical implications? Perhaps one that's notorious for causing diagnostic headaches.
One notable anatomical variant that warrants extra attention due to its profound clinical implications, and indeed can cause significant headaches, is the superficial ulnar artery, or SUA. It's a rare occurrence where the ulnar artery arises unusually high up, either in the axilla or the arm, and then follows a superficial course in the forearm, often just beneath the skin, before entering the hand and contributing to the superficial palmar arch.
Running superficially, danger bells ringing.
Precisely. A bilateral high origin from the second part of the axillary artery is exceedingly unusual, with reported incidences ranging from approximately 0.17% to 2.0% when it originates from the axillary artery, although a slightly higher incidence of 4.2% is seen when it originates from the brachial artery. This variation, though rare, is critical to recognize. The clinical implications of an SUA are profound precisely because of its superficial course. It can easily be, and tragically often is, mistaken for a superficial vein during routine procedures such as venipuncture for blood draws or IV cannulation, leading to accidental intra-arterial drug infusion. This, as we know, can result in severe tissue damage, arterial spasm, thrombosis, and sadly often amputation. Furthermore, its presence complicates percutaneous brachial catheterization, as clinicians might inadvertently attempt to access this aberrant artery. There's also a significant risk of severe bleeding during trauma or reconstructive surgical procedures such as skin flap transplantation if the SUA is unexpectedly encountered and injured.
A surgical surprise nobody wants.
Indeed. Moreover, it can complicate the preparation of free forearm flaps, particularly those with neurosensory potential, and radial artery grafting for coronary bypass procedures, where the usual expected vascular anatomy is altered. Therefore, careful palpation of the antecubital fossa and forearm during preoperative clinical examination, and crucially, Confirmatory diagnosis with Doppler studies are absolutely essential to minimize these substantial risks. It's also clinically significant in the context of arterial anastomosis performed for hemodialysis, where a thorough understanding of vascular patterns is paramount for successful long-term access. These embryological variations are often just unlucky breaks in development.
But vigilance is key.
But our vigilance can prevent tragedy.
That's a powerful reminder that basic palpation and, when in doubt, a quick Doppler can prevent catastrophic outcomes. Beyond these fascinating anatomical variants, what other acquired or congenital conditions can compromise hand circulation, leading to significant clinical challenges that we, as clinicians, need to be hyper-aware of?
Beyond anatomical variants, several acquired or congenital conditions can profoundly compromise hand circulation. One such condition, crucial for us to identify due to its severity, is thromboangiitis obliterans, also known as Berger disease. This is a rare inflammatory disease that primarily affects small and medium blood vessels in the arms and legs, leading to their occlusion and often distal ischemia. It has a strong and well-documented correlation with cigarette smoking, to the point where cessation of smoking is the single most critical intervention.
Smoking cessation is non-negotiable there.
Absolutely. Patients frequently present with symptoms like Raynaud phenomenon or levator reticularis, which manifest as characteristic skin discoloration due to reduced blood flow. The Allen test is often positive in affected limbs, indicating profoundly compromised collateral circulation, and severe cases can unfortunately lead to tissue loss and amputation. Another common condition, often less severe but still impactful, is Raynaud's disease or phenomenon. This is characterized by vasospasm, where smaller blood vessels in the fingers and toes and sometimes other areas like the nose or ears narrow excessively in response to cold temperatures or emotional stress.
The classic white, blue, red sequence.
Exactly. This leads to characteristic symptoms. The affected areas often turn white due to lack of blood flow, then blue as blood pools, and finally return to normal pink or red upon warming, often accompanied by a prickly feeling or stinging pain. Raynaud's can be primary, meaning it occurs without an underlying cause, or secondary, where it's linked to other conditions such as connective tissue diseases like scleroderma, lupus, or rheumatoid arthritis. Carpal tunnel syndrome, smoking, injuries to the hands or feet, or even certain medications like beta blockers. In severe cases of secondary Raynaud's, prolonged reduced blood flow can lead to tissue damage, skin sores, or even necrosis, although this is fortunately rare but must always be considered.
So secondary Raynaud's needs a deeper workup.
Definitely. Other critical issues affecting hand vascularity include aneurysms, which are weaknesses in artery walls that can expand like a balloon. These can form clots internally, which might then scatter smaller clots distally to the fingertips, leading to acute pain, numbness, color changes, or even gangrene. Traumatic injuries are a direct and often immediate threat. Cuts or severe stretches to vessels can cause immediate and critical blood flow cessation, requiring urgent surgical repair, often primary anastomosis or vein grafting, to salvage the limb.
Time is critical there.
Absolutely. Finally, vascular malformations, which are often congenital, involve tangled or abnormally connected vessels, such as arteriovenous malformations. These can lead to symptoms like swelling, pain, warmth, increased growth of a part, and sometimes bleeding, significantly impacting the functional integrity of the hand. Understanding these diverse conditions alongside anatomical variations is key to comprehensive and truly effective hand care.
It's abundantly clear that the hand's vascularity is absolutely fundamental to its health and viability. But how does this intricate network of vessels and its anatomical structure all translate into the hand's remarkable functional capabilities, making it the indispensable tool we use every single day? And crucially, what are the specific vascular demands or vulnerabilities of these functions?
A hand is truly unique. It's an organ of reception, interpreting our environment through touch, an organ of execution, performing myriad tasks, and a primary organ of communication, expressing thoughts and emotions. Its incredible functional integrity relies not just on its intrinsic structures like the bones, joints, muscles, and nerves, but also profoundly on the stability of the trunk and arm.
The whole kinetic chain.
Precisely. Without a stable base, the precision and power of the hand would be severely limited, regardless of its vascular health. A normal functioning hand is capable of a vast array of actions, encompassing everything from expressing emotion to palpating structures, grasping objects of all shapes and sizes, manipulating tools with fine dexterity, pushing, carrying, and even the simple act of counting. Its design truly reflects its multi-purpose nature, and every one of these actions demands a robust, adaptable, and uninterrupted blood supply.
Out of all the digits, the thumb seems to command a special status in hand function. What makes it so indispensable, and how does its unique anatomy and function tie back to its vascular supply?
The thumb holds an undeniably pivotal position. It is undoubtedly the most important digit due to its unique ability of opposition. This movement isn't a simple flexion. It's a complex multiplanar combination of abduction, flexion, and axial rotation, allowing the thumb tip to touch the tips of any of the other four fingers. This comprehensive opposition fundamentally distinguishes humans from other primates, most of whom cannot fully oppose their thumbs, which is why humans typically exhibit a double palmar crease in contrast to a single crease in many primates.
That's saddle joint mobility.
Exactly. The anatomical arrangement of its carpometacarpal, or CMC, joint, a biconcave saddle joint, provides exceptional mobility crucial for this unique function. Now, connecting this back to our vascular discussion. The profound significance of the thumb is immediately apparent when it's lost. Its absence results in a massive deficit in precision grip, fine manipulation, and overall dexterity, severely impacting almost every aspect of hand function. The thumb's blood supply primarily comes from the princeps pollicis artery, often a direct branch of the radial artery or the deep palmar arch. Given its critical functional importance, its vascular supply is surprisingly not as redundant as the rest of the digits.
So it's more vulnerable then.
It can be. This means the thumb is particularly vulnerable to radial artery compromise or issues affecting the deep palmar arch, making accurate preoperative assessment of its collateral supply crucial. Compromised radial artery flow, for example, can immediately show up as deficits in key precision tasks involving the thumb, making it a critical diagnostic clue.
That makes perfect sense. How do the other fingers contribute to the hand's overall function? And how does the loss of each finger impact daily activities, especially considering their vascular profiles?
Each finger contributes uniquely to the hand's overall functional repertoire, and their functional importance correlates somewhat with their specific vascular supplies. The index and middle fingers are primarily involved in precision functions, working closely with the thumb. For example, the most functional oblique arch of opposition is between the index finger and the thumb, facilitating precision grips. While the loss of the index finger can reduce flexion force by about 20%, the hand often adapts remarkably well, with the middle finger frequently compensating for most functions, though some width of grasp is inevitably lost.
The middle finger takes over.
Often, yes. Its vascular supply, like the middle fingers, comes mainly from the common digital arteries off the superficial palmar arch, which tends to be more reliably complete. The middle finger's loss, however, leads to a greater loss of flexion strength than index finger loss, and can create a significant functional gap in the palm, making it particularly difficult to hold small objects like coins. This is because the second and third metacarpals form the rigid portion of the longitudinal arch, essential for stability.
Stability is compromised.
Exactly. The ring finger's loss generally results in the least functional deficit among the fingers, but also creates a gap in the palm, again impacting the ability to hold small items. Its blood supply is similarly robust from the arches. The little finger, despite its seemingly small size, contributes significantly to power grip. Its peripheral location and the unique ability of its metacarpal to flex at the carpometacarpal joint enhance its capacity to grip tools securely and affect receptive function, especially when combined with a hypothenar mass. Its loss can lead to a substantial narrowing of the digital and palmar span, impacting grasp out of proportion to its size.
So the little finger punches above its weight for power.
It really does. This understanding is critical for both prognosis and rehabilitation strategies, and it's why preserving blood flow to the ulnar side of the hand, even when the radial seems dominant, is always a priority for power functions.
Beyond the individual digits, the hand's overall shape is defined by its inherent arches. How do these arches contribute to its dynamic function, and what happens if they collapse? And how does the vascular supply maintain the viability of these crucial structures?
The hand's bones are not arranged in a flat plane, but rather in dynamic arches that are absolutely critical for adapting to various objects during grasping and manipulation. At rest, the hand naturally relaxes into a gentle cascade from the radial to the ulnar side across the metacarpal heads. In a tight fist, this cascade becomes even more pronounced, promoting power on the ulnar border. With fingertips pointing intrinsically towards the scaphoid bone, any rotational deformity, perhaps post-fracture, becomes obvious if a digit doesn't point correctly, indicating a structural disruption.
A useful clinical sign.
Very much so. There are three main arches. The fixed proximal transverse arch, with the capitate bone as its keystone, providing a stable base at the level of the distal carpus. Then there's the more mobile distal transverse arch, which passes through the metacarpal heads. These two transverse arches are connected by the rigid portion of the longitudinal arch, primarily formed by the second and third metacarpals, which act as a stable pillar. The mobility of the first, fourth, and fifth rays around this rigid central core allows the palm to flatten or cup, accommodating objects of various sizes and shapes.
That adaptability is key.
Absolutely. Additionally, there are 4 oblique arches of opposition, the most functional being the one formed between the index finger and the thumb, facilitating precision grips. The integrity of these arches is paramount. Collapse in any of them, whether due to bone injury, nerve damage affecting intrinsic muscles, or ligamentous laxity, can lead to severe disability and deformity, drastically impacting the hand's ability to grasp and manipulate. Critically, these arches are themselves vascularized by branches from the palmar arches and dorsal networks. If their bone or soft tissue components lose their blood supply, structural integrity is lost, leading to collapse and, consequently, severe functional impairment. It's a fundamental interdependence.
You mentioned the tenodesis effect earlier as a valuable clinical assessment. How exactly does this phenomenon provide useful information about the hand's condition, especially regarding tendon integrity and nerve function?
The tenodesis effect is a natural passive phenomenon where movement of the wrist produces reciprocal movement in the fingers and thumb, assuming all muscles are balanced and relaxed. It's an incredibly useful and simple clinical assessment, particularly for detecting tendon ruptures or contractures, and it gives us quick insights into the integrity of the extrinsic, flexor, and extensor tendon muscle units.
How does it work in practice?
Well, here's how it works. When the wrist is passively flexed, the finger should naturally extend at the metacarpophalangeal, or MCP, and interphalangeal, IP, joints while maintaining the normal cascade of the hand, and the thumb will sit in abduction. Conversely, when the wrist is passively extended, the fingers are pulled into flexion, again towards the scaphoid, and the thumb moves into adduction and opposition. Any deviation from this normal pattern, for example, if a finger remains flexed when the wrist is flexed, suggesting an extensor tendon rupture or flexor contracture.
Or the opposite way around?
Exactly. Or fails to flex when the wrist is extended, suggesting a flexor tendon rupture or extensor contracture, can indicate injuries to nerves affecting muscle tone, tendon ruptures that prevent transmission of force, or joint contractures that physically restrict movement. It offers valuable diagnostic clues about the functional integrity of the extrinsic flexor and extensor tendons, and the overall balance of forces across the wrist and hand, all reliant on well-perfused muscles and tendons.
Finally, let's bring it all together by discussing the primary categories of hand function: power grip versus precision handling. How do these differ fundamentally, and what anatomical components, especially vascular ones, are critical for each?
Hand function can largely be simplified into 2 overarching categories: power grip and precision handling, each demanding different muscle synergies, precise anatomical alignments, and unique metabolic requirements that are met by their vascular supply. Power grip involves a combination of strong thumb flexion and adduction, combined with powerful flexion of the ring and small fingers on the ulnar side of the hand. For maximum force generation, the wrist must be in slight extension and ulnar deviation, which optimally positions the extrinsic digital flexors for mechanical advantage.
Positioning for power.
Exactly. This position leverages the synergistic action of the extensor carpi radialis longus and brevis and the extensor carpi ulnaris. Examples of power grip include using a hammer, gripping a baseball bat, or shoveling. Variations of power grip include the hook grip, which primarily relies on the strength of the flexor digitorum superficialis and is used for carrying objects like a briefcase or a bucket. And the cylinder grip, where the fingers and thumb flex around a cylindrical object. The power in a cylinder grip is significantly provided by the strength of the ring and little fingers opposing the thumb, highlighting the critical role of the ulnar side of the hand in forceful tasks. These powerful actions require substantial, sustained energy and thus a robust, high-flow vascular supply, predominantly supported by the ulnar artery and the superficial palmar arch, which are crucial for maintaining the endurance needed for these tasks.
Okay, so ulnar side for power. What about precision?
Precision handling, on the other hand, primarily employs the radial side of the hand, specifically the thumb, index, and middle fingers. In precision grasp, the wrist position is less critical than in power grip, and the intrinsic tendons of the hand provide most of the fine finger movement. The compression force for precision is primarily provided by the extrinsic muscles, but is intricately aided by the interosseous muscles, the flexor pollicis brevis, and the adductor pollicis, which is crucial for adduction of the thumb, making the grip powerful.
Intrinsics are key here.
Absolutely. The opponent's pollicis further assists through rotation of the first metacarpal, allowing for the true opposition that defines human dexterity. This category encompasses a wide range of tasks and specific pinch types, such as tip pinch, used for picking up a small pin, palmar pinch for holding a playing card, lateral pinch for grasping a key, tripod or three-jaw chuck for holding a pen, and span grip, used for opening bottles and jars by encircling the object with the tips of all fingers and the thumb. Each precision grip requires exquisitely fine motor control and the intricate interplay of intrinsic and extrinsic hand muscles, all critically dependent on a robust and uninterrupted vascular supply, particularly from the radial artery and deep palmar arch, to sustain their precise, energy-demanding actions.
Radial side for precision.
Generally, yes. In fact, compromised radial artery flow can immediately show up as deficits in key precision tasks like a tip pinch, making it a critical diagnostic clue in your assessment.
What a journey through the hand's vascular world. From the fundamental arterial anatomy and the critical assessment provided by the Allen test, to understanding those often surprising rare variations and the profound implications for clinical practice. It's clear that the hand is a microcosm of complex biological engineering demanding our deepest respect and understanding.
Indeed. Recognizing these intricate details and their potential variations is not just academic. It directly influences our ability to diagnose accurately, plan interventions safely, and ultimately truly improve patient outcomes. It underscores the continuous need for thorough clinical evaluation and an adaptive mindset in the face of anatomical individuality. It's about anticipating the unexpected rather than reacting to a crisis.
And that concludes our deep dive into the vascular anatomy of the hand. We truly hope this exploration has provided you with valuable insights to enhance your practice and perhaps challenged a few assumptions. And if you found this deep dive beneficial, please take a moment to rate and share the show.
Thank you for joining us.
As you reflect on this, what's one specific subtle vascular anomaly or variation that you now feel better equipped to recognize in your own practice? And how might that understanding continue to shape your approach to those truly complex hand cases, preventing a potential complication before it even starts?